Welcome to this presentation introducing basic theories related to the use and misuse of psychoactive substances. Developing this presentation was one commitment in the 2019 expansion of Practitioner Education grant awarded to the Council on Social Work Education from the Substance Abuse and Mental Health Services Administration. During the two-year project, CSWE is implementing a high-quality, standardized substance use disorder curriculum to strengthen preparation of future social work practitioners to deliver effective, evidence-based substance use disorder prevention, treatment, and recovery services. So, you might be wondering why social workers bother with theories of substance misuse when all we really want to do is help people experiencing substance-related problems or prevent these problems from developing in the first place. How will knowing theories, especially so many different theories, help you make a difference in the real world? One major reason for studying theories is to inform our interventions for helping people get past and recover from problems with substance misuse, how to prevent people from getting into trouble with substance misuse in the first place, how to prevent use of alcohol or other drugs from becoming a substance use disorder, and how to make families, schools, workplaces, neighborhoods, communities, and our world in general healthier places to live and grow. When we apply a solution to address an alcohol or other substance-related problem, that solution is based on a set of assumptions, theories, or models concerning how the problem came to be, what factors and mechanisms contribute to the problem emerging and maintain or sustain its existence, and what might reasonably be expected if we intervene to change or manipulate those influencing factors. Theory and the evidence supporting our theories, or models, provide a blueprint to guide our intervention efforts. Social workers prefer our intervention efforts to be informed by theory and evidence rather than taking random chances with people's lives. The trick is that there exist many relevant theories and models related to substance misuse for us to consider. This presentation provides a general orientation and structure for understanding them. You'll need to develop a deeper understanding as you continue learning to practice in the area of substance use, substance misuse, substance use disorders, and recovery. The theories and models presented align reasonably well within a biopsychosocial framework. Once the framework has been outlined, we identify several biological theories and models relevant to substance misuse, use disorders, and recovery. Then we identify quite a few theories and models within the psychological domain and another set that fall within the social context and physical environment domain. In this context, the Circularity of Influence model is briefly explored. All of this is followed by a brief discussion that gets back to a more integrated biopsychosocial framework, especially as it might inform prevention strategies. A final topic is introduced as it relates to substance misuse theories and models. How we might think differently about generalized versus specific models concerning different types of substances. In terms of multiple theories for understanding substance use, similarities, differences, and important points of intersection exist. The biopsychosocial framework provides an organizing framework to clarify what otherwise might seem like just a jumble of ideas. This framework suggests two important things. First, biology, psychology, social and physical context domains are each important in understanding the processes related to substance misuse and recovery. Some scholars and clinicians add the spiritual as an additional domain, but for purposes of this presentation, spirituality is integrated in the social and physical context domain. Second, The biopsychosocial framework emphasizes interactions and relationships between these three domains. These three domains do not operate as independent silos. They intersect, overlap, and interact in meaningful and synergistic ways. For example, consider the ways that the neurobiology of learning interacts with psychological learning processes to produce the often observed cue-induced triggers and cravings. Or, for example, consider the ways that spirituality crosses boundaries between social and physical contexts, where we placed it, and the psychological and biological influences as well. The mechanisms by which mindfulness practices support recovery demonstrate this kind of integration across the three domains. One point that all the evidence indicates is that there exists no one single cause of substance misuse and substance use disorders. There's not even one single domain. Substance misuse, substance use disorders, and recovery are very complex phenomena influenced by multiple interacting factors. This is one reason why it can be so different an experience for different individuals, and why one-size-fits-all solutions simply don't. They don't fit all. In the biological domain, we're interested in the ways that different biological factors might influence a person's substance use initiation, and their substance use becoming substance misuse, or a substance use disorder. On the flip side, we're also concerned with how substance misuse might affect a person's biology and physical health. Assumed in all of these discussions about possible effects is the possibility of developing a substance use disorder. Together, we want to know how to intervene at a biological level to prevent substance use disorders and to support recovery. An additional point related to the effects of substance misuse concerns how this information can help inform harm reduction efforts. These are interventions aimed at reducing the probability and severity of many different potential harms arising from substance misuse, even when reducing substance misuse itself is not the immediate goal. Starting with the biological mechanisms that affect substance misuse and substance use disorders, genetic influence models have piled up a great deal of evidence. For example, evidence supports a model of genetic contributions to a person first initiating use of nicotine or nicotine-containing substances like cigarettes and vaping. A great deal of evidence points to the genetic leaks in the transition from alcohol misuse to an alcohol use disorder, a compilation of evidence from twin, adoption, family pedigree, and genomic studies. Genetics contribute to positive protective mechanisms as well, not just vulnerability. For example, there's a genetic basis to some individuals experiencing an intensely negative flushing response to alcohol. This punishing physiological response potentially protects a person from engaging in alcohol use in the future. An estimated 36% of persons of East Asian genetic background experience intense facial flushing, nausea, and rapid heart rate in response to alcohol exposure because of the genetics behind their ability to break down alcohol metabolism byproducts. Jumping briefly to the effects topic, this genetic mechanism also makes individuals more susceptible to alcohol-related cancers as well, because it operates by extending the time and concentration of exposure to damaging alcohol breakdown metabolites in the body. Back to genetic influences. Considerable evidence exists for a genetic contribution to alcohol as well as other forms of substance use disorder. But the most important of all take-home lessons is that genetic influences interact with other biological, psychological, and social context mechanisms. Genetics alone do not determine a person's destiny. Outcomes are quite variable depending on a whole complex of factors involved. For example, looking at an individual person's pedigree or family tree, it's impossible to fully separate the genetic pattern from the social and physical environment influences. Just because the child of a person with substance use disorder also develops a substance use disorder does not mean that the transmission from one generation to the next was strictly genetic. Other family and social or physical context forces may be involved. Additional biological mechanisms beyond genetics warrant attention. For example, exposure to alcohol or certain other substances at critical points of brain development may influence a person's susceptibility to or probability of developing a specific substance use disorder later in life. In the case of alcohol exposure, evidence indicates that drinking before age 15 was associated with a 4 times greater rate of alcohol dependence during adulthood than was observed among adults who did not drink before the age of 21. Plausibly, this is related to disruption of the normative developmental brain changes that occur during adolescence. The differences may also be attributed to personality differences between individuals who begin drinking early and those who delay initiation. Personality differences which may result from genetic and early biological influences on temperament. The impact on adolescent and adult substance use patterns related to prenatal brain exposure to various substances is also a question explored through research. For another biological influence model, consider that individuals experiencing chronic, severe physical pain may be prescribed opioid medications to help manage pain, which could result in a development of an opioid use disorder over time. However, opioid misuse can also have the effect of lowering a person's pain threshold or pain tolerance, which might also influence opioid misuse once it's initiated. Turning to how substance misuse affects a person's biology and physical health, we have at least 3 areas of concern for theory to address. First, there exists considerable evidence about different substances and their specific effects on the human body's organs and organ systems. This includes the association of substance misuse with a number of non-communicable disease states, such as diabetes, cancers, high blood pressure, cardiac problems, and others. We know that chronic, heavy alcohol consumption, for example, has harmful effects on the brain, heart, liver, pancreas, immune system, and multiple forms of cancer. Similarly, we know a great deal about the negative physical health effects of smoking tobacco products and are learning about the effects of vaping. Less is understood about the potential long-term effects of heavy cannabis use. We also know that alcohol, tobacco, opioids, cocaine, barbiturates, and other substances can have very many negative effects on a developing fetus if used during pregnancy. Substance misuse and associated behaviors surrounding substance misuse may increase a person's potential exposure to infectious diseases, including sexually transmitted diseases, as well as unplanned pregnancy. For example, sex for drugs exchanges are an associated behavior of concern. Or, for example, shared or reused needles with injection drug use potentially exposes a person to infection at the injection site and other blood-borne infections, such as HIV and hepatitis. Reducing these public health risks is one aim of clean needle syringe services, harm reduction programs. Additionally, substance misuse and associated behaviors may reduce a person's resistance to infectious disease. They may become more seriously ill if they do become infected. Third, many psychoactive substances affect coordination, mood, judgment, memory, information processing, motivation, and other cognitive functions. For example, according to the World Health Organization, about 1/2 of the world's 1.8 million deaths attributable to alcohol are from either unintentional or intentional injury, including suicide, assault, and falls. And as previously noted in the discussion about pain, injuries can result in chronic pain that contributes to substance misuse. Thus, it's critical to understand biological factors if we're to understand and effectively intervene around substance misuse. For example, understanding the biology of substance misuse and substance use disorders has contributed to the development of various mindfulness-based and pharmacotherapy strategies for supporting individuals in recovery. Now let's move into the psychological theories domain. The list of psychological theories and models to consider is both long and varied. When we talk about understanding psychological processes, we're generally talking about the way that people think and feel. We're not just interested in what they think and feel, we're also interested in the mechanisms by which thinking and feeling operate. Cognition is about thinking and thought processes. This includes how we take in information, how we learn, our learning styles, how we manipulate information and ideas, how we understand the world around us, and understand our experiences, our problem-solving approaches, what we remember and how we remember it. There's absolutely no doubt that cognition and cognitive processes are integrally entwined with biological processes, as well as being integrally entwined with substance use disorders. The very nature of psychoactive substances is that they affect the way a person experiences the world, thinks, and behaves. Thus, it's important to consider how information processing theories relate to substance use and misuse. Information processing is about what happens between a stimulus event and the behavior a person exhibits in response to that stimulus. First, in an information processing model, many types of substances have an impact on perception, the way any of a person's 5 senses receive input information, and also perception of their own internal bodily states. For example, pain perception. Or, for example, you may have noticed that social gatherings get louder as alcohol is consumed. This is in part because increasing alcohol levels dampen a person's hearing acuity, so they overcompensate with increased speaking and music volume. Next in the information processing model is memory, how perceived information becomes stored in memory. Many different types of substances affect how perceived information is transferred into short and long-term memory. Some may even cause a form of amnesia, whereby no memory for an event is ever formed. Date rape drugs, for instance. In addition to these immediate short-term memory distortions, chronic and heavy use of certain substances may damage areas of the brain where long-term memories are stored. Then there's the influence substances may have on a person's ability to retrieve or recall certain memories. For example, a person may find it difficult to remember information or how to perform a skill learned under the influence of heavy alcohol use when trying to recall it without alcohol in their system. This is a concept called state-dependent learning. A person need not progress to the point of alcohol blackout to have difficulty with memory retrieval or recall for events that occurred while drinking heavily. Together, these steps in information processing help explain why individuals might behave very differently when they engage in substance use compared to when they do not. Another psychological aspect concerns feelings, emotions, our affect. How we label our feelings has a lot to do with how we respond when we experience them. This is a link between affect and cognition. If we interpret or label a situation as calling for us to feel mad or sad or bad or even glad, we've developed certain types of responses to these emotions. If substance use was the response developed to any of these feelings, then we're likely to use that as a response again when we feel those feelings in the future. By the way, how did you interpret the screen beam character on this slide? Is this character running forward to joyously hug someone feeling glad? Or is this a case of running away from something scary, feeling panicked or fearful? Or is it an expression of extreme frustration throwing their hands up in the air? So you see, the way we cognitively interpret a situation has a lot to do with how we behave. In psychoanalytic and psychodynamic theory, addictive behavior is a symptom of intrapsychic conflict or unresolved psychological tension and turmoil. This is where the concepts of id, ego, and superego come into play. The id represents choices for responding to our urges and raw emotions. The choice of using alcohol or cannabis or other substances is a possible response to intense negative emotion, allowing a person to escape or numb those intensely uncomfortable feelings. Through experience with the social environment, the superego develops a commitment to behavior that is acceptable in the person's social world. The superego editorializes about choices the id has hatched. For example, self-shaming about one's own substance use. A considerable degree of tension develops between the two forces, or wills, the person experiences. Some individuals describe their experience as actual voices they hear inside their mind, arguing with each other, sending them shaming and blaming messages. The ego develops as the manager over this miserable tension between the id and superego. The ego serves as a referee between the strong urges to behave in certain ways coming from the id and the strong pressure not to behave in those ways coming from the superego. The decision to use substances like alcohol, cannabis, and some other psychoactive substances is sometimes a solution to silence the superego, putting it to sleep, not only to satisfy the id's desire to remove the unpleasant emotional experience, but also to remove the unpleasant, tension-filled experience of the conflict between the id and superego. Substances might be misused in an attempt to quiet loud, negative voices inside the mind. Yet another psychoanalytic interpretation of addictive behavior, particularly for smoking tobacco, cannabis, or vaping products, is related to the concept of oral fixation. In psychoanalytic theory, it's part of the normative course of development that a person's libidinal energies become localized at a specific zone in the body at different periods of development. Libido does not only refer to a person's sexual drive. Earlier in development, libidinal energies localize in the oral zone, around the mouth. Stimulation of the oral zone feels good because it relieves the tension in that area caused by the localized libido. Orality is a period of infancy. We expect to see babies using their mouths to explore the world. According to psychoanalytic theory, if something happens at this early orality phase of development to trap some of the libido in the oral zone, the person will spend a lifetime trying to satisfy the need for oral stimulation, putting things in the mouth, chewing or sucking on things, cigarettes, cigars, even vaping units. In this theory, these oral behaviors are viewed as an effort to curb the demands from the trapped libido. Logically, a person should be able to substitute one oral tool for another. In other words, chewing gum or drinking from water bottles should be able to resolve a need to smoke. It's not so simple, though. The cigarettes, cigars, or vaping tools come to cause demands of their own from the chemicals involved. Not sure what that's all about. Infants and young children in the normative course of development form attachment relationships with caregivers, central to their physical and emotional survival. Parents, siblings, caregivers, even pets and some special objects, like a blankie or stuffed animal. These psychological attachments are what allow us to have the sense of security in a great, big, unpredictable world. Sometimes attachment relationships are disrupted. They fail to form at all, they're broken once formed, or they form as an insecure, unstable attachment. According to attachment theory, a person with attachment issues is likely to experience significant holes in their emotional and personality development. The world does not seem like a safe, predictable, reliable place, nor are there safe and predictable people on whom the person can rely. Sometimes these individuals describe themselves as being full of emptiness. Such a person may come to rely on alcohol or other drugs as a means of coping with the pain and loneliness of these holes and gaps. Substance use might numb the psychic pain and sense of detachment. And the drinking or drug-taking social environment itself may be what they use to fill the emptiness inside. It's not necessarily the alcohol or drugs, but the drinking or drug-taking situations that start the pattern. But if it progresses, the drugs or alcohol begin to place their own demands on the person. The intervention implications related to psychoanalytic, psychodynamic, and attachment theory models of substance misuse are that the original sources of conflict, loss, or other disruptions need to be identified and resolved. Therapies that repair the psychic damage help the person become whole and fill the empty voids. This is the therapeutic goal of many forms of psychotherapy and individual counseling approaches. The preventive strategy is to help create developmental contexts, including early infancy and childhood, where the person is psychologically nurtured. You may have heard about the concept of an addictive personality. The idea was that someone's personality characteristics make them likely to initiate substance use or develop a substance use disorder once it's initiated. These days, the idea of an addictive personality is considered somewhat out of date, as it's not well supported by evidence. The idea is challenged by recognizing that there are no specific personality characteristics that all people engaging in addictive behavior share in common. Another challenge is that traits or characteristics that have been identified as common among individuals engaging in addictive behavior are not unique to this population. Others share those traits too. The evidence indicates that pretty much any person can develop a substance use disorder if the right, or in this case the wrong, circumstances come together. Some personality types may be more vulnerable or at a higher risk of developing certain types of substance use disorder, but the potential is there for anyone. For example, a 5-factor model, +2, suggested that neuroticism, extroversion, openness to novel experience, impulsivity, and sensation-seeking, combined with low agreeableness and conscientiousness, predicted use of psychoactive substances. There's a great deal of correlational data suggesting that certain traits are more commonly associated with substance use initiation, substance misuse, and substance use disorder. But correlation does not demonstrate causality. Substance misuse could just as likely be the cause of changes in personality, or some third factor could be the root of both the substance misuse and the personality traits. Thus, there remains a great deal of controversy as to the existence of a generalizable addictive personality type. In other words, a person experiencing a substance use disorder is not a separate type of person. Consider what might be the intervention implications of personality influences on substance misuse. It might help with early identification of persons who might be most vulnerable, but what would it suggest we actually do about it? Changing personality is a very difficult challenge. A great deal of evidence surrounds the psychological and neurobiology basis of learning related to substance use evolving into a substance use disorder. Reinforcement and punishment principles form the basis of operant conditioning learning models and help explain how specific and general substance use behaviors are shaped and then maintained once initiated. Classical conditioning helps explain the way that substance use and misuse behavior is maintained once certain stimuli have become paired with substance use through this learning paradigm. This learning theory explains the experience of cue reactivity, or cue-induced craving triggers, intense desires to engage in substance use again being triggered by encountering paired stimuli. These craving experiences pose a threat to a person's recovery efforts. Closely tied to these learning principles, social learning theory also contributes to an understanding of how substance use or misuse behavior is initially acquired and then possibly maintained. A person's social world is the source of many types of reinforcement and punishment for substance use and misuse that are relevant to learning through operant conditioning. Additionally, observational learning is a phenomenon identified in social learning theory. This model reflects on the many different behavioral models to which a person is exposed in their social context, models whose behavior the person might choose to imitate. These learning theories inform a variety of intervention strategies. For example, cue exposure therapy is designed to systematically desensitize a person to their cue-induced triggers and may be supported by coping skills training to help a person respond in healthful ways when a craving is triggered. Or, for example, the community reinforcement approach to treating alcohol and other substance use disorders is based on an operant conditioning principle. Prevention strategies often employ models of healthful behavior in recognition of observational learning as a powerful influence on behavior. Cognitive theories inform a great many evidence-supported interventions for addressing alcohol, tobacco, and other substance misuse or use disorders. These include cognitive behavior therapies, or CBT, and cognitive behavioral coping skills training interventions, CBCST. The theories relate to how behavior follows from how a person interprets an event or experience. The nature of the interpretation determines a response. Thus, it might be helpful to either intervene to help someone interpret the experience differently, leading to a different behavioral response, and/or to prepare the person with new responses to the experience as interpreted. Here's a simple example where cognition is relevant. Two different ways of interpreting the experience of encountering a grizzly bear in the wild. If it's interpreted as dangerous, the reasonable response is to escape, to run away. If, on the other hand, it's interpreted as awesome, the response might be take a photograph. In relation to substance use, we could put any of a number of experiences in the stimulus box. Being offered a cigarette, cannabis, vaping device, drink, or other drug is only one possibility. How a person assesses or interprets the offer determines their behavioral response, whether they accept the offer or decline. In this example, whether they end up smoking or not. Perceived as risky, the person might not accept the smoke. Perceived as rewarding, making someone feel good, they might accept and smoke. So as previously discussed, this cognitive model relates to a host of recovery support and treatment intervention options. An important aspect of a person's cognitions about alcohol and other substance use concerns their expectancies about the positive or negative effects of using those substances. In that middle step of appraisal between the stimulus and the behavioral outcome, expectancies influence appraisal, hence the behavioral outcomes. Positive expectancies promote substance use, and obviously, negative expectancies have the opposite effect. Expectancies are shaped by direct personal experience and interactions with the social and physical environment, family, peers, media, and advertising, for example. Having an expectancy that using cannabis will make you feel happy and relaxed might influence your appraisal and choice about using cannabis when the opportunity arises. On the other hand, having an expectancy that using cannabis makes you dull-witted and impairs your reflexes may influence your appraisal differently, leading to a different outcome. Expectancies are a powerful risk factor for heavy alcohol use, have demonstrated effect on use of cannabis products, and may very well operate in the misuse of other substances. Evidence exists that alcohol expectancies develop among early school-age children, and that childhood expectancies predict how early in life someone first becomes drunk, and when they begin to engage in binge drinking. Expectancies are further shaped by these early drinking experiences as well. Our next topic is developmental theories or models. These come in two forms. One having to do with an effort to map a common developmental course or trajectory of substance use disorders, and the other related to how substance use and misuse intersect with the course of individual life course development. An example of the first is a three-stage model of addiction, beginning with binge use and intoxication, evolving into withdrawal and negative affect, and capped with preoccupation, anticipation, and craving. Other examples of stage models related to the progression from substance use to developing a substance use disorder include the natural history of alcoholism proposed by Jelinek in the 1950s and 1960s, and expanded upon by other scholars since then. The original Jelinek model progressed in 4 phases between the pre-alcoholic, prodromal, crucial, and chronic phases. These kinds of theories reflect a belief that a common trajectory to addiction or substance use disorder exists. Note, however, that in that kind of model, there's no recovery. On the other hand, the stages of change element of a transtheoretical model of behavior change proposes that there exists a spiral-shaped developmental progression to the recovery process. Individuals engaged in substance misuse or experiencing a substance use disorder may first have no plan to make change in their behavior. At some point, they may begin to recognize that a problem exists and begin to consider not only the need to make changes, but consider ways that change might be achieved. This would be moving from pre-contemplation to contemplation. Subsequently, a person may begin to make concrete preparations to change, and then engage in specific actions to achieve a change goal. Eventually, they may achieve a new state where the change is now the new normal, and they engage in efforts to maintain the hard-won changes. The spiral notion comes into play in that people commonly move up and down in this sequence, not necessarily in a single direction. One implication of this model is that we need to implement different types of intervention matched to each different stage. Still, other scholars argue instead of there being a single developmental trajectory, for instance from functional to chronic severe disorders, the argument is that there exists a typology of different ways that substance use disorders manifest. This pie chart represents results of a reanalysis of data from the National Epidemiological Survey on Alcohol and Related Conditions, NESARC for short. The authors identified 5 clusters or subtypes of individuals who met criteria for an alcohol use disorder, and argued that these subtypes are qualitatively different and do not fall on a developmental continuum. In addition to developmental trajectory models, another whole type of developmental model exists. These models address the intersections between human developmental process and substance misuse. For example, behavioral under control theory explains why individuals might be more susceptible to engaging in substance misuse during adolescence than during other developmental periods. It draws on biological models of adolescent brain development, involving functional revision to the areas responsible for inhibiting behavior, lagging behind changes in areas responsible for initiating behavior. As a result, adolescents exhibit behavioral under control, meaning that they're more likely to engage in risky behavior, playing with fire, so to speak. The drive to act is under controlled by inhibitory forces. Behavioral under control in the course of normative development eventually becomes replaced by greater inhibitory control and better judgment that influence behavior. Here's another example of the second form of developmental model. The evidence presented on this slide depicts data from the first wave of NESARC. The graph demonstrates that the prevalence of meeting criteria for drug dependence disorder during a person's lifetime using DSM-4 criteria is related to the age at which drug use was first initiated. The prevalence of a lifetime substance use disorder was greatest among individuals whose drug use began at or before age 13, way up there on the left at 33.6, and that it dropped pretty steadily across adolescence and emerging adulthood. Prevalence among individuals whose drug use initiation was delayed to age 20 was down to 11.4 and 13.6 for those who waited until age 21 or older. All of these developmental theories and models have implications for prevention, early intervention, and recovery support. While there remain other psychological theories and models to consider, we'll wrap up our discussion of psychological models with self-medication theory. This is closely entwined with what is recognized as an association between trauma and substance use, misuse, and use disorders. A great deal of evidence illustrates a high concordance between trauma and substance misuse and substance use disorder. Trauma related to adverse childhood events, or ACEs, and trauma occurring during later developmental periods, including trauma related to military service experience, intimate partner violence, sexual assault, and other life and limb-threatening experiences. According to self-medication theory, individuals may seek to medicate their psychological pain, anxiety, grief, and depression with alcohol or other substances. It also suggests that individuals with attention deficit disorder and other mental disorders may be doing the same, attempting to treat themselves with psychoactive substances. An obvious implication for intervention is that these individuals be supported in addressing and managing their underlying trauma and psychological concerns with evidence-supported interventions instead, and that substance use disorders emerging from their efforts at self-medication be addressed as well. Thus, it's critical to understand psychological factors if we're to understand and effectively intervene around substance misuse. For example, understanding the psychology of substance misuse and substance use disorders has contributed to the development of multiple behavioral and counseling strategies for supporting individuals in recovery. This brings us to the third and final domain of the psychosocial perspective on substance misuse. What's going on in the social context and physical environment? And here we include spiritual factors as well. There exist many more theories and models addressing social and physical context factors than presented in this list. This is just a start. Ecological systems theory, originally attributed to Yuri Bronfenbrenner, is at the heart of the person and environment social work framework. From a biopsychosocial perspective, while we need to consider their internal biological and psychological processes, we can never truly understand a person's behavior without also considering the environmental context within which the individual lives, grows, learns, develops, and functions. Even if we come to understand an individual's most immediate social context, like their family, we still need to consider the social and physical context within which that social system operates too. And we need to consider the nature of the interactions and interfaces between systems, moving outward from the individual to their microsystem, which is where their most regular immediate interactions occur, out to the meso, exo, and macro system, where culture, policy, and service delivery systems have their influence. Just as the individual's social and physical context influence their behavior and development, the individual influences their social context as well. This evokes the concept called circularity of influence. Circularity of influence models are more complex than simple cause and effect models, where input factor A causes output behavior B. Consider, for example, the possible relationships between a person's immediate family and friend contexts, and that person engaging in heavy drinking. It may be that the family models heavy drinking as an emotional coping mechanism. The peer group positively reinforces heavy drinking and discourages not drinking or drinking in moderation, and both family and peers provide easy access to alcohol in excessive amounts. These are inputs that could directly contribute to a person engaging in heavy drinking behavior. While these aspects of the social context, A, might influence heavy drinking behavior, B, changes in the person's drinking behavior, B, also might come back to affect the social context, A. For example, it may lead to increased arguments within the family. These changes in the social or physical context may continue to affect change in the individual's heavy drinking behavior, B, and so forth, back and forth, in an iterative pattern of influence over time. Additionally, over time, membership in the person's social network may change, as those who do not approve of heavy drinking remove themselves, and others who engage in heavy drinking join. This is just one example of the circularity of influence pattern in operation. The social and physical context also may shape the individual's behavior away from heavy drinking, towards drinking in moderation or not drinking at all, in the same kind of iterative pattern, supporting recovery or preventing a substance use disorder from developing out of heavy drinking patterns. In short, circular patterns of influence are iterative over time and can be amplifying or dampening. They can make a problem worse or better depending on the influences involved. What might be the social work intervention implications of ecological system theory? It suggests that our interventions should not all be directed in change the person strategies. If we truly believe in this person and environment model, we should also be considering two other general approaches: changing the person's environment and changing the way the person and their environments interact or interface. In other words, social workers need to consider the goodness of fit principle. It's equally plausible that a person's substance-related problems are intrinsic to the person, situated in the person's environment, or related to the interaction between person and environment. It also suggests that we have multiple spheres of influence where we might intervene. In the microsystem, we might intervene with the family, friends, and significant others to support an individual's recovery efforts. In the mesosystem, we might address our efforts to the workplace or school. In the exosystem, we might intervene to change the care delivery system to better support an individual's recovery process. At the macro system level, we might intervene to change policy from a punishment approach to one emphasizing treatment access, or to change stigma that impedes a person from seeking help for their substance-related problems. Spirituality and religious affiliation span all of these spheres, from the individual at the center to their family and friends, formal and informal spiritual and religious organizations, and on out to the largest sphere. The ecological model has us already thinking in a systems term, so let's turn our attention to family systems theory. A really critical facet of the social and cultural microsystem for any individual is family, and family is as defined by the individual, not limited to legally defined relationships. Despite many of our social stereotypes, most individuals, including those experiencing substance use disorder, are involved in complex social networks that often include family. Family systems theory helps elucidate some of the circularity of influence patterns in operation when an individual engages in substance misuse. The key tenets of family systems theory include that families are embedded in and interface with other social systems, just as we saw in discussing the ecological systems theory. This means extended family networks, neighborhoods, workplaces, and schools, criminal justice, healthcare, and social service delivery systems, and so forth. Families are embedded in multi-generational extended family systems in both a historical sense as well as in the present. This is where social workers often employ eco-mapping as a technique for exploring how individuals and family systems interface with other elements of the social, physical, and institutional environment in which they're embedded. Second, a family system is greater than the sum of its parts. In other words, family has meaning to its members, and we cannot understand a family system simply by knowing who is a member. This suggests that some decisions may reflect the needs of the family as a whole, superseding the needs of an individual. Third, family systems operate through interacting subsystems. For example, couples, parent-child, sibling subsystems with their own rules of engagement that are affected by and affect the system as a whole. In many instances, families describe a member's involvement with alcohol or other drugs as being a subsystem all its own, that the person has a relationship with the substances, and that the person's substance subsystem affects all the other subsystems and the system as a whole. Intervening with couples who engage in substance misuse together, whose entire relationship was founded within the context of substance use, can be challenging, as the substance use is an integral part of their relationship. Helping one partner change threatens the balance of the entire relationship. Fourth, family systems are dynamic over time, and change of any kind, positive or negative, is costly to families in terms of energy and effort involved in adapting or adjusting to change. Because of the three principles already discussed, we know that change in any individual has a ripple effect throughout the entire family system. This helps explain why family systems are not always as receptive to a person's recovery efforts as might be hoped for. They may, through a great deal of effort and pain, have learned to adapt to the person's substance misuse and family disruptive behaviors. They may have achieved a new, hard-won state of balance or homeostasis. It's a great deal to ask that they re-engage with the change process and adapt once again to accept the changing person, hopefully supporting their recovery, especially if they've been through that cycle a few times with the person. It's not that they perversely wish that the person continues their substance misuse. It's more that changing the family system in response to the individual's change efforts and recovery efforts is a costly enterprise. Clearly, the family system represents a context for shaping substance-related expectancies, where substance use and misuse may be modeled by family members, and where substance use behavior may be reinforced or punished. In other words, as a context where the learning and cognitive expectancies, those principles previously discussed as psychological, happen. But it's critical to recognize that family systems are also a context where abstinence or responsible alcohol and other substance use might be modeled. Family members may discourage substance misuse through delivery of reinforcement and punishment. Negative expectancies about substance use may be fostered. Family systems are a context for other protective factors that warrant attention in terms of preventive strategies, helping protect children, adolescents, and emerging adults from engaging in serious levels of substance misuse. Evidence concerning these preventive factors identified parental warmth as an important aspect of preventive parenting. These parents have warm relationships with their children, are able to provide emotional support and comfort, and act as a sounding board for reflecting values and interpreting life experience. In addition, preventive parenting involves a significant degree of parental monitoring, such that an adolescent knows that risky behavior they engage in will be found out by the parent, and because of the nature of their relationship, the young person cares about the parent's opinion of them. They care about not disappointing their parent. These parents impose age-appropriate levels of behavioral control over their child or adolescent. Moving outside of social and emotional space, it's critical to acknowledge the influence of physical environment, including the degree to which environments provide opportunity or easy access to alcohol and other substances. Access refers to the availability of preventive factors and accessibility of recovery support as well. No matter how much biological, psychological, and social forces are stacked in favor of a person developing a specific type of substance use disorder, this simply cannot happen if the person never encounters that substance type. Unfortunately, in our society, it's impractical to remove all access. For example, there exists evidence that family and friends are the primary source of access to pain medications used non-medically, and evidence that individuals often take their first drinks as children or adolescents in their family home. Another example of physical environment influences relates to the evidence that alcohol, tobacco, and vaping products are advertised, and that advertising is often targeted to specific racial, ethnic, and age group populations. It shows up on their neighborhood billboards as neon signs in local markets, and more recently as targeted advertising in social media sites. As cannabis becomes legalized in more communities, a similar pattern may emerge. We're not only concerned with individuals' access to substances, but to prevention and recovery support services as well. This leads to community and macro-level considerations, looking at some of those larger spheres in the ecosystem. For example, there exists enthusiasm among scholars and practitioners for integrative and coordinated systems of care. This includes bringing evidence-supported screening and treatment services into primary health care and other natural settings like schools and workplaces. It also includes expanding case management and wraparound service models that coordinate systems of care concerned with substance misuse, mental health, physical health, housing and food security, economic and employment stability, child welfare, and criminal justice. The drug court model is just one example. Not only do social workers engage in case management for recovery support, they advocate for improved access to a range of integrated and coordinated recovery support services. An aspect of the social context relates to the nature of the substance-related social norms held by members of a person's surrounding community and social networks. Social norms reflect a set of behavioral rules, guidelines, and expectations espoused by the social groups to which a person belongs. Family and peers are two locales where norms are expressed. Norms also are expressed in the media, from institutional resources such as what we learn in school or at work, in political campaigns, public health messaging, and social policy, among other sources. Substance-related norms often involve the expression of expectations concerning who uses what substances, when, where, and how. They also involve expressions favoring or discouraging substance misuse and intoxication. Sociological theory concerning deviance norms is relevant to this discussion as well. A key point about social norms is that they have an impact on individuals' behavioral choices. Another is that individuals are likely surrounded by competing messaging from the norms they encounter in different social groups or settings, a kind of ambivalence. What they hear from family, church, or school might not be the same as what they hear from peers and social media networks. Some prevention messaging have the possibility of backfiring if they emphasize that too many in a peer group use or misuse substances. Rather than seeing this as the problem, the message may interpret it as substance use or misuse being common and thus normative. Everyone else is doing it, so it's something they should do too. For instance, data from the 2019 Monitoring the Future study showed that 25.5% of 12th graders had engaged in nicotine vaping during the past month. Rather than emphasizing that somewhat alarming 25.5%, we might want to emphasize instead that almost 75% didn't. By not vaping, you are in the majority. This is what social norms looks like. The Monitoring the Future study also provides a rich body of data about 8th, 10th, and 12th grade students' attitudes, beliefs, and norms concerning a wide array of different substance use behaviors. Perceived harmfulness of different drug use patterns, their own disapproval levels, their perceived attitudes held by their parents and friends, and more. These norms data help inform prevention strategies with these age groups. More recent longitudinal data are also available concerning emerging adults who were previously studied as high school students. A significant aspect of the social context concerns stigma, disparities, and social justice issues related to substance misuse. These issues concern biases built into systems of care. For example, bias in screening and assessment protocols, referral patterns, gender and cultural competence of interventions, and other aspects of the system of care and recovery support. For example, if certain populations are not screened or referred for assessment, their needs will go undetected, and the system will not provide expensive services. An instance of this sort of disparity is failure to properly screen and refer individuals who are incarcerated. The criminal justice system will not provide substance-related services if the need is not recognized in the first place. Another social justice concern relates to service models, such as group treatment, and their accessibility to individuals who identify as LGBTQ+. In many communities, LGBTQ+ individuals may feel very uncomfortable and unwelcome in treatment groups, possibly even in individual treatment sessions. Social justice issues related to substance use and misuse extend to global systems and co-occurring issues. Consider, for instance, our nation's relationships with countries where drugs are produced, trafficked, exported, and imported, whether sanctioned or not by the governments involved. Substance-related activities play a significant role in global economics and politics, particularly in our nation's relations with Central and South American, Central European, and Asian countries. Not only do these forces and relations influence what happens with illicit substances in communities across the nation, they influence the availability, quality, and safety of prescription pharmaceutical drugs as well, as evidenced by, among other things, specific shortages that occurred during the coronavirus pandemic, tremendous cost variability in similar drugs across countries, and safety recalls of multiple kinds of medications due to potential contamination. Social justice aspects of substance-related activities intersect with issues of intimate partner and community violence, human trafficking, weapons trafficking, money laundering, and funding terrorist groups. Social dominance models raise social justice concerns as well. These models address intergroup inequalities being maintained through legitimizing myths that provide moral and intellectual justification for privilege and discrimination. Consider, for example, some of the prevailing stereotypes regarding alcohol and other drug misuse among different racial and ethnic groups, such as myths regarding alcohol and First Nation members, designated as AIAN in the NSDUH study, or regarding cannabis and Latino men. It's critically important for social workers to remain informed about and critically analyze implications of current epidemiological evidence concerning disparities in substance use patterns and access to substance-related services. Additional social justice influences result from policy responses to substance-related issues. For example, racial inequalities in incarceration rates are attributed to the nation's historical war on drugs. Significant disparities resulted, for instance, between incarceration of individuals arrested for powdered versus crack cocaine offenses, reflecting differences between more affluent white individuals who tended to use powdered cocaine and less affluent black individuals' use of crack cocaine, despite these groups using the same drug, cocaine. Incarceration trend data also led to the war on drugs being labeled a war against black women. Additionally, the topic of stigma surrounding substance misuse and how stigma affects substance use behavior and recovery warrants an entire presentation on its own. On the flip side, a body of literature is emerging concerning the impact of exposure to racial microaggression on substance use among emerging adults. So we introduced several types of social context and physical environment theories concerning substance use, misuse, use disorder, and recovery. As was true for the biological and psychological domains, these theories and models have significant implications for how we choose to intervene, and you're encouraged to delve more deeply into the models and their supporting evidence. Now that we've introduced a host of theories from the separate biological, psychological, and social context or physical environment domains, here's an opportunity to reintegrate them into a biopsychosocial perspective. This integrative conceptual framework has significant implications for planning prevention intervention strategies. Step 1 in this conceptual framework involves carefully defining the target population, the target problem or concern. The topic of substance misuse is far too broad, as is preventing substance use disorder. It is necessary to narrow the focus to a specific population, substance type, and behavior. For example, preventing vaping initiation among adolescents, or preventing heavy episodic drinking among college students, or preventing injury and death from intoxicated driving. Step 2 of the conceptual framework involves reviewing the evidence related to two key dimensions: evidence related to vulnerability and resilience, and evidence related to risk and protection. This framework makes important distinctions between vulnerability and risk. These terms are not to be used interchangeably, at least not in this model, nor are the terms resilience and protection. Vulnerability and resilience are viewed as falling on a continuum of intrinsic factors, those factors that individuals bring to any new situation. Evidence might refer to vulnerability related to a person's genetic or other biological factors, such as early brain exposure. Vulnerability and resilience also refer to psychological factors, past experiences, attitudes, values, what they learned, or co-occurring challenges. All of these would be part of the vulnerability and resilience to the issue of concern. The elements in this continuum and whether they represent vulnerability or resilience factors are determined in literature. The risk and protection continuum, on the other hand, refers to extrinsic factors, those social and physical environment factors that are relevant to the issue of concern. For example, this might relate to social norms, access to substances, access to recovery support, policy and enforcement practices, and social capital. Again, the nature of risk and protection continuum is determined by evidence. Note that the word risk here does not infer probability that a problem will emerge. It refers to a specific type of influencing factor. An example helps reinforce the distinction between intrinsic vulnerability resilience factors and extrinsic protection and risk factors. Consider social reinforcement of drinking. Reinforcement that occurred in a person's past becomes a part of the person's intrinsic learned experiences. The person brings that past learning to any new situation. It's a vulnerability factor. On the other hand, currently drinking within a reinforcing context is an extrinsic situational risk factor. It's currently part of the person's environment. The third step in this conceptual framework allows us to integrate evidence on the vulnerability resilience continuum with evidence on the risk protection continuum. A note of caution here, because the evidence is based on group data, population data, and models, this framework is applied to the population level. We don't yet have the technological sophistication to apply it at individuals level. Let's look at the prevention planning implications of this integration. At the group or population level, we can generally predict the probability that the issue of concern will occur. This helps us direct scarce prevention resources where they will have the greatest likelihood of positive impact. It also helps us determine where to direct our preventive efforts, what kind of preventive strategies to employ. In the first cell of our integrated grid, the probability that the issue of concern will develop among individuals with low vulnerability, situated in low-risk environments, is low, even without delivering any significant preventive effort. These individuals might also have intrinsic resilience and extrinsic protections. Thus, as long as we accurately identify vulnerability and risk as being low, with resilience and protection being high, we can direct our preventive intervention efforts elsewhere. These folks are going to be fine. Of course, this implies that neither continuum shifts in the wrong direction over time. For the moment, let's skip over to the last probability group, Group 4. These are individuals who function in high-risk environments, lacking in strong protective factors, coming to these environments with high vulnerability and low resilience. For this group, the probability that the issue of concern will emerge is high. This is a group where utilizing a great deal of prevention resources could have a strong positive impact. The aim of prevention could be either reducing vulnerability and enhancing resilience, or aiming to reduce environmental risk and enhance protection. All of this would move the population either towards group 3 or towards group 2. Ideally, prevention efforts would be directed towards modifying both and moving this population more toward group 1, where the probability of the problem emerging is low. So in between groups 1 and 4, those extremes, we have two groups where probability of the issue arising is moderate. Prevention efforts with group 2 might best be directed toward reducing their vulnerability and enhancing their resilience, thereby moving them more towards the lower probability group 1. As long as this group remains in a low-risk environment, their probability of developing the issue of concern is moderate. So prevention efforts might also be directed towards maintaining that low-risk environment and shoring them up with environmental protection. This will help prevent their slipping into that high probability group 4. Likewise, prevention efforts with group 3 might best be directed toward reducing the risks in their environment and boosting their protections, with the aim of moving them more toward the low probability group 1. And as long as their vulnerability remains low and resilience high, they're not likely to slip into that high probability group 4. Thus, some of our efforts might be aimed at ensuring they do not develop new vulnerabilities or lose resilience. Probably the most important take-home lesson of this integrative biopsychosocial framework regarding vulnerability, resilience, risk, and protective factors is that no one single type of preventive intervention is likely to be sufficient. We need to tackle these substance-related issues of concern from a position of complexity based on what the various sources of evidence about biological, psychological, and social context and physical environment tell us matters. The second most important message is that while we need to be attentive to the vulnerabilities and risks related to a specific issue of concern, we also have the benefit of a strengths perspective where we can explore resilience and protection as well. One final theoretical principle to consider is the extent to which a particular theory or model covers the phenomena of substance misuse and substance use disorders in a generalized way or is more specific. Does it apply regardless of which substances are involved, treating them all as one and the same, or only to specific substance type? On the other hand, it's possible that the underlying processes differ for different substances, requiring unique and different theories and models depending on which substances are involved. The evidence suggests that neither and both are correct. There exist some similarities and areas of overlap across types of substances, but each type of substance has some unique factors as well. This is a very different picture from where there was 100% overlap or from where there was zero overlap. In this final picture, there might be a very small area in which all overlap. There might be areas where some overlap occurs between certain types, but not all types of substances, accompanied by areas of uniqueness related to each type of substance too. This certainly presents a very complex model and helps us understand why there's no such thing as one umbrella theory or solution. For instance, investigators exploring the question of a genetic basis to substance use disorders in general have asked, is there such a thing as an addiction gene, one that is relevant regardless of the type of substance involved? The conclusion is basically no. There is no one single gene pulling for or protecting from substance use disorder across all substance types. However, there are some areas of overlap, for instance, in the genetic underpinnings to alcohol and opioid use disorder. It's less clear whether the psychological or social and physical context theories are appropriately applied in a more general manner or need to be applied more specifically. Again, most likely, there are areas of overlap and areas of uniqueness involved. So, the first key point from this presentation concerning multiple theories and models related to substance misuse is that our wide array of theories offers an array of solutions and opportunities for intervening. These include efforts to reduce the harms associated with substance use, what harm reduction is all about. The second is that the various theories can be systematically organized by adopting the biopsychosocial perspective central to our social work profession and supported by many other disciplines. In this context, you were briefly introduced to quite a few biological, psychological, social context, and physical environment theories and models concerning substance use initiation, substance misuse, substance use disorders, and recovery within this biopsychosocial perspective. Then you were introduced to an integrative conceptual framework related to evidence concerning vulnerability, risk, resilience, and protective factors. The concept of circularity of influence was introduced, as was the discussion of applying generalized versus specific perspectives to different types of substances involved. Hopefully, this presentation has provided you with a conceptual system for pursuing theories and models in greater depth to better inform your intervention efforts. Thank you for your attention and consideration throughout the presentation. I'll click quickly through the references. You can pause if you want to see more. Again, thank you.